Hello, good morning, everyone. Hope you all are doing great today. I'm Sri Sharma from H&E Labs, bringing you the live kidney pathology series. We already have more than 200 attendees online currently, and people are still joining. So we'll give a few more minutes to everyone join, and then we will start. Just 1 minute more, and after that, we can start. So in the meantime, as you all are joining, you can see the poll on your right side. So if you can answer the poll, that will be great. That will help us to plan future webinars in a better way. And I would also like to give you a brief background about the series. After our online KidneyCon live Zoom talk last month, we received multiple requests to continue the kidney pathology series. Therefore, we started this live kidney pathology series in conjunction with NephJC, KidneyCon, and NephSim. We will present classical educational topics and interesting case reviews in this series. Our aim is to provide kidney pathology education for nephrologists in training and also practical day-to-day practice relevant information to the practicing nephrologist. Today, Samira, Matt, I, and Tiffany are going to moderate the session. Tiffany and I are kidney pathologists at H&E Laboratories. If you have any questions during the talk, please write them in the chat box, and one of us will address the question appropriately. If you are in the field of nephrology, you know both Samira and Matt. Both of them are very interested in medical education and are leveraging social media to enhance learning in nephrology. You can Google them up and find out everything about them. I'll give you a super abbreviated introduction for both of them. Samira is an assistant professor at Mount Sinai, New York, and practices nephrology and transplant nephrology. She is the associate director of the Nephrology Fellowship Program and social media director of the Division of Nephrology. She is the co-founder of NephSim. Matt is an assistant professor at Duke University School of Medicine, North Carolina. He is the director of medical student research and associate program director of the Nephrology Fellowship Program. He is a faculty member of the Nephrology Social Media Collective, also known as NSMC, member of the board of directors at Nephrology Journal Club, also known as NephJC, co-founder and advisory board member of the AJKD blog, and co-creator of the popular educational project, Neph Madness. All three of us, Samira, Matt, and I, along with John Arthur at UMS, are involved with KidneyCon. Now I will request Samira to introduce our speaker for today.
Thanks, Sri, for the kind introduction. Welcome to everyone. It's great to see so many people here on a Saturday morning on the East Coast. So I have the pleasure today of introducing Dr. Patrick Walker, who will be our speaker today. He is the founder of H&E Labs and has more than 40 years of experience in the interpretation of native kidney and transplant biopsies, so that's older than I am. Before founding H&E Laboratories, Dr. Walker was chief of the Department of Pathology and Laboratory Medicine at the John L. McClellan Veterans Administration Hospital and vice chairman of the Department of Pathology and Laboratory Medicine at the University of Arkansas for Medical Sciences, as well as on the faculty in the Department of Pathology at Tulane University. He has a passion for advancing the understanding of disease and has authored more than 100 peer-reviewed research articles, and in addition has received numerous teaching, research, and service awards. So with that, Dr. Walker, welcome. Thank you again for joining us. I'm looking forward to hearing your talk on Introduction to Kidney Pathology.
Hello, everybody, and it's good morning here in the central United States. It's a rainy day in Arkansas. I'm going to go ahead and share my screen so I can start the talk somewhere over the rainbow. How did I already forget how to do that? There's my sharing option. Share my screen. Okay, there it is. I found it. Share that screen and start the talk. So today my subject is an introduction to the medical renal biopsy in 2020. The why, the how. That's what I'm going to try to get through here so that we have a better understanding of what we're doing, why we're doing it. And some of this is truly introductory. You already know it. You've already thought about it. But let me just put it into perspective. So these are the primary reasons that people will perform a diagnostic medical renal biopsy. And the reason we still need to take tissue, in spite of all our advances over the last 20 years in genetics, proteomics, blood work, everything, is because these syndromes are so nonspecific for any individual glomerular disease. If you're going to do a renal biopsy, you need a renal pathologist with a real renal path laboratory, and you must have good interaction between the person requesting it, the nephrologist, and a pathologist who understands what's going on with kidney disease. I just wanted to highlight, we're not going to talk about this very much. You know, transplant biopsies make up about 20% of our practice. That may be a little high, 18 to 20%. And oh, by the way, we do 16% pediatric biopsies. Love working with the pediatric nephrologists, great crew, love working with all you guys. But look at every one of these, just a list. And my favorite is always other, because there's so many other things. And when you're doing a transplant problem, well, I've got a rising creatinine of 0.2. And any one of these things may be the problem. Now you just start your workup, but you end up often doing a kidney biopsy. Acute kidney injury is the least likely to get a biopsy because so often the cause is obvious, but sometimes it isn't, or the cause is obvious and the patient just isn't getting better. So a biopsy can help not only with diagnosis, but with prognosis. So why is it so hard to do? Because the kidney is so complex. When I start thinking as a pathologist generally and the complexity of various organs, certainly the brain is extremely complex in its function, but you know, it's cellularly, it's relatively simple. Relatively, I'm not trying to offend any neuropathologist, but when you look at the kidney, there are so many different parts of it, and it's so complicated that that's part of the reason, plus its interaction, why we end up doing biopsies. So let's do a 90-second, second-year medical school review of the kidney. You always, when you're teaching your students who are rotating with you, always remind them where the kidneys are. They forget that the kidneys are at the back of your body, right below the ribs. I mean, they think they're somehow in the middle and that you should be doing an anterior approach. They've forgotten their gross anatomy because I tried to forget all of it after my anatomy classes. I was quickly flushing it all. But there is a renal capsule that's quite glistening and covered with fat. This one's been cleaned up a bit. And when you cross-section it, you're going to see medulla and the cortical areas and the renal pelvis and vessels and things like that. Another major factor that people forget is just how thin the cortex is. I'm trying to show you with a ruler here the 10 millimeter length of a cortex, reminding you that there's about 1 million to 1.5 million glomeruli in this area. I have a lot easier time visualizing it if I think about M&Ms. Every country in the world has a substitute for M&Ms if they don't actually have M&Ms. And it turns out that the diameter of one small chocolate or colored M&M is 10 millimeters, the exact thickness of the cortex. Time out, when you're doing a biopsy, that's your aim. You got 10 millimeters to work with. You got to hit that M&M hard candy shell, get through it, and then get the solid chocolate in the middle and nothing below it. Oh boy, did this bring you back to first year med school? The nephron's the functional unit of the kidney. And I love the simplification because this is how simple I am. If you actually start examining the tubules and the collecting duct, and there are many people in this audience who know this in detail and have studied channels and gates and all of these things in the different segments. It's so complicated in a wonderful way. Here's the other thing that we forget. The nephron filters 180 liters from the blood every day, and all you put out is 1.5 liters. Now just imagine for a minute a liter bottle, and then put up 180 of them. And then look at 3 pints, which is, in America, that'd be pints. It's a half a liter container down there at the bottom. 80 liters a day. Of course, I think in gallons, since I'm in the United States, and it's 47.5 gallons. So again, I look at a gallon milk bottle, and there's 47.5 of those. I'm sorry, I still get totally overwhelmed at the complexity, the interest, the fact that we don't just pee ourselves to death every day. It's amazing what the kidney does. Always.
Hey, Matt, this is Matt.
Go ahead, Matt.
Do you mind if I interrupt and ask you a quick question?
Sure.
Let's say that hypothetical situation, and you had interventional radiology doing biopsies for you, and you had a couple come back that said all medulla. Your pathologist calls you from Arcana and tells you that. What would you tell the interventional radiologist? What is the most common reason for missing cortex?
Oh, Matt, you have just this. When I get through this 90 seconds, we're going to be talking about that in detail, and I'm going to demonstrate to you how that actually happens so you can go tell them. So if you'd hold that question for just a second or two, you're going to see the answer visually. Remember, I'm a very visual person. Is that okay, Matt? I hope it's okay, because I'm moving on. Because we're still in the intro part, and I just wanted to demonstrate to you. So if we take that same medulla down here, cortex, and then start moving into pathology. This is a PAS stain. Here are a couple of glomeruli. And remember, the glomerular volume is only about 5% of the kidney. There are various special stains. This is the H&E stain, the standard path stain. And here's a PAS, which is so lovely, with the PAS positive brush border, the peritubular capillaries, which are so important in transplant, right there, and the urinary space right there, in the tubular lumen right there. There's a schematic on the left, which shows you the takeoff point of the proximal tubule, the so-called tip area, the afferent arteriole, which comes straight in, and the efferent arteriole, which wraps around and meets the tubule behind. Here's a light microscopic picture that just captured it perfectly. Here's the takeoff point of the proximal tubule, the tip area. Here's the root of the glomerulus where the vessels would be coming in. And then immediately jump to high power to get a clear idea of just why we're able to filter so much. Here's the capillary space with red cells in it, the urinary space, podocytes, mesangial region. And if you go to very high power, there's the mesangial area. The endothelial cell pokes its nose into the lumen. There's the glomerular base membrane, the urinary space. And this allows you to convert to electron microscopy. So here's the reverse image: mesangium, capillary space, urinary space. And we do a lot with the electron microscope. We're the only team except for Neuropath that still uses it to any great degree. So there's the mesangium with a bunch of loops coming in and out of your screen. High power view, glomerular base membrane, capillary space, urinary space, foot processes with slit diaphragms. This is a picture I took in 1978 when I was at Tulane and was doing my own EMs and got it way high magnified because I'd never really appreciated the slit diaphragm before, and I've kept this picture ever since. This is the capillary space, foot processes, GBMs, and off the screen would be, did I say capillary? This is the urinary space. The capillary space is off the screen. This is what we all thought until the late 90s, that the glomerular base membrane with its podocyte slit diaphragm, the endothelial cells, was nothing more than a physical gate or fence. That's all it was, with a negative charge. All those little black lines are negative charges. Well, about 1998, things started to change, and this is a relatively recent diagram of what the podocyte contains, what's going on in here. We're not going into this physiology today, but of course, a couple of these are my favorites, like TRPC6. I always love the, all of us who are geeks went into medicine, and we named things the way we would have in high school, I think, TRPC6 and fat. There's NFAT. I like NFAT. We got a bunch of those kind of things. All right, now we're going to get into the question that Matt asked. Because every time you do a renal biopsy, you better do a pre-test analysis. Really understand what you're doing, what you expect to find, and is it going to impact your therapy or the prognosis? We sometimes get apologies from nephrologists saying, oh, I thought it was just going to show X, Y, or Z, but I just had to be sure. Let me tell you, that's an important reason to do a kidney biopsy, impact therapy, or be able to tell the patient their prognosis. Who's doing the biopsy? Right back to your question, Matt. This takes really good technique, and it can't just be done mindlessly and idly. And finally, who's interpreting that renal biopsy? This should be a fellowship-trained renal pathologist. The how. In general, I'm not going to go into all the oddball ways things get done, transjugular, all these other things. In general, it's a posterior approach, usually the left kidney. Today we do ultrasound a lot or CT. Conscious sedation, local anesthesia. Children may require even general. Here's the most important question.
A question.
Sure.
Why is there a reason for the left kidney preferentially that you mentioned?
It has to do with, it's generally lower down, and your target area is not, will not miss and get that gigantic liver. If you're going to miss, you're going to get the spleen. Of course, you know, that's a toss-up. The liver is a lot safer to biopsy than the spleen, but the spleen is much smaller. So your miss, if you're going to miss deep, is more likely to be not as dangerous. You're not going to get a big piece of liver. All right, needle gauges. So,
Can you hear me?
yes.
Do you mind just on your pointer, can you move that a little slower and maybe make it bigger? Is it possible so people can see what you're pointing to?
Let me try to use the laser pointer. How's that?
Better.
All right, well, I'm sorry about that. Let's use that. I should have noticed that. I apologize. All right, biopsy guns. Sure. I get so excited. I get talking. So biopsy guns. 14 gauge to as small as 22 gauge, 22 gauge, 22 gauge. If you biopsy tissue, 22 gauge, and pick it up just very carefully with pickups or forceps, and just hold it in the air, the tissue will float. That's how thin a 22 is. 20 isn't much better. The standard gauges used in a renal biopsy are 18, 16, and 14. And what I'm showing you there is the internal diameter of these biopsy needles. Well, that doesn't tell you very much. Say 300, 600, 900 is what that's telling us. But what you have to understand is the normal diameter of a glomerulus is 225 to 250 microns. What? 250 microns. Look at that 18 gauge. Well, let's look at it visually. So here's an 18 gauge compared to the 250 normal glomerulus. So I put the line here and measured the 250. And you get, at best, if they were almost right on top of each other, 1.5 glomeruli in an 18 gauge. And I'm going to keep demonstrating this to show you just how awful. Matt, this is key to your question. We'll get to that. They do 18 gauge biopsies. This leads to problems. So this is just a gross photograph taken with a cell phone of what the slides look like when we cut them and put them on a section, on a slide. So this, I'm sorry, what the sections look like when we cut them and put them on a slide. So this is a normal 18 gauge biopsy. Doesn't look that much different than a 16. Looks a lot different than the 14. But when you're doing serial sections, you get, this is a volume equation. So you're getting 3 times the volume of an 18 gauge needle with a 14 gauge. So as we do serial sections and cut through the tissue you sent, I'm already running out of tissue. 16 is holding up. 14 says, bring it on. Plenty of tissue left. How about looking at a very low power? This is actually 100x. All three of these were taken at 100x and measured. And I measured a whole bunch of kidney biopsies to get sort of a mean biopsy width with different gauges. So the mean biopsy width with an 18 is 290. Remember, the glomerular width is 250 to 200 to 250. 16 gauge is a huge improvement. And of course, a 14 gauge, the 14 gauge fills the section that at 100x, fills the whole thing. So look at that difference. This has been studied. I've got references for every single thing I'm showing you if anybody wants the individual reference. So where did I get the 50%? Somebody who has too much time on their hands went back and looked at a bunch of 18 gauge needles and calculated how many glomeruli are fragments floating or missing, and showed that about half of them are the reason you know they're missing is you'll have an empty Bowman's capsule. Like this guy hung in there, but he could have just as easily floated off into the fixative. Or maybe he has an attachment very thin at another level in the section, like here. You can see that this one has popped out of its Bowman's capsule. It's just hanging on the edge.
Dr. Walker, maybe you're coming to this in a bit. Could you comment on the risk of bleeding with the different gauge needles?
Yes, we're going to talk about that. There's zero difference in serious complications or minor complications between 14, 16, and 18 gauge needles. The difference in complication is the operator, not the gauge.
Thanks.
If you look back to the late 90s, early 2000s, at papers published by nephrologists doing biopsies, again, I have all the references. If the operator is qualified, the bleeding risk is identical. And I have a slide on that to demonstrate this. That is so important. And we're going to get to why the bleeding risk increases with poor operators. As we get through looking at these, you're going to see why that can be a problem with bad operation. So this is my recommendation, just based on a lot of reading. If you have a child up to the age of 7, use a 16 gauge needle. Nobody does a 14 anymore, but you could. In 2000, and a total aside here, I'm actually getting a huge abstract ready for submission to the SN on thousands of kidney biopsies done at Arcana, and showing the change in miss rate from the 2001 era when I first started to currently, and the size of biopsy needles done back then. A significant number in 2001 through 2005 were 14 gauge, just to give you a hint. Bleeding complications the same. But what do we get? Over 80% of our biopsies are 18. Most are, and some are 20. The rest are 16. Nobody does 14 anymore. Okay, let's get back to doing the kidney biopsy. All of this is introductory to everybody who does them, but I like to just make sure that the people in the room remember that we do need a pre-biopsy ultrasound. I want to emphasize one thing, especially if interventional is doing it, or you're doing it and you don't know, you're not trained how to look for a mass lesion. Hello, you're in there looking to find cortex and you totally ignore the fact that there's a renal cell carcinoma in that kidney. IR does that. We have had medical renal biopsies with no idea there was a mass lesion in there that was 100% renal cell carcinoma. In other words, they hit right what they targeted, but because they were thinking this is medical, they didn't imagine the mass. This is the old trick. I'm very old, back when we would bring films, chest films, to the wards and show them to our staff, if anybody remembers that. But imagine it the same way. You're looking at the film on the screen and you ask the second-year medical student, well, what do you see? And they immediately focus, heart size is normal, there's no infiltrates in the lung. They forget the cancer that's metastatic, right, visible in the scapula. It's because what you think you're looking for is what you look at. So don't forget to look for cysts and mass lesions. Shameless plug for our sample kit from Arcana. This is what we send out. This kit has been run over on its way to us by a FedEx truck. We've had 5 times that's happened since 2001. 5 times. The kit got run over and flattened. They delivered anyway, but but because of the structure of the inside of that kit, the sample was completely preserved. The glass was broken, everything was broken, but because tissue fixes quickly, we were able to sort through, find all the tissue, and the Michelle's is separate from the formalin, so it survived. You need a good kit that you're sending it in, not some Uline little box wrapped in bubble wrap with the two bottles bouncing off of each other. You need a good prep area to handle what you're looking at. So now we've got to do our ultrasound for correct needle approach. I'm not quite, again, I don't do this, so this actually is aimed correctly. We're at the lower pole, and I don't quite know how they got this shot, but that's what we're looking for right here. We want to be at the lower pole and not aimed this way.
Can you tell us a little bit about why we should aim for the lower pole?
Yeah, and I think that's on our next picture here. So to me, when I look at the ultrasound, I don't have a good idea what that means. So here I'm preaching to you about doing an ultrasound and looking for a mass, and I think anatomically, histologically, and gross organ, I think this shows you why you want to aim at the lower pole. Just look at the size of this artery right here. There's one right there. This is a surgical pathology specimen. So the cancer's up off over here, and I just cut the picture off so you don't see why they took this. But this was a young person who had a cancer. So we've got a nice normal cortex. So you want to be here aimed at the lower pole, maybe get a little bit of medulla and mostly cortex, but look right there. There's a vessel right there. So you have to be careful even at the lower pole. Well, sometimes you're aiming at the lower pole, but you get the incorrect angle. So now you thought you were aiming this direction, but you're actually aiming this direction. You're actually aiming for the papillary tip. So if you look at, you're actually aiming for the CMJ, and in this one, you're actually aiming at the papillary tip. So when you're doing the biopsy, you're all taught this way. IR is not, you are. You go to the capsule and stop. You feel it bouncing right here. When you're there, you feel it bouncing. The tendency is to say to yourself, oh, I'm right there. I just need to get inside the kidney. Let me just a little deeper, just a little deeper. And when I do a little deeper, I punch through a stiff capsule, relatively stiff, and you can't hold yourself back. That punch through gets you almost entirely through the cortex. You're almost entirely through it. And the problem is, if you start here and you fire the gun, that's what you get. That's the throw. The gun throws the needle that far. You've totally missed on the one side. Now it's upside down. All the cortex is on the other. But look what you just poured through here. So this is why all this practice, the angle, this isn't trivial. Somebody asked earlier about complications. Everybody gets gross hematuria, 10% gross. Most patients will have some microscopic hematuria, everybody. But I want you to look at the title of this slide, Complications for All Three. So here's a paper from 2000. The papers that show this are mostly 80s, 90s, early 2000s before IR took this over. By now you've read through this slide. Here's the only complication for 14 versus the other two. The patients who are not under conscious sedation, who are only under local, will feel pain when if you got started outside the capsule, then fire the gun. As that bigger needle punches through the capsule, they will feel like somebody punched them. Remember, it's not like a sharp pain because this is visceral pain. It feels like somebody went and hit them with a fist. And they will report that in a slightly higher percentage than the other two gauges. I slowed down here to emphasize to you, there is no difference here. It's the operator that counts. All right. Most IR have quit looking at the tissue. They wander through, go room to room to room. They pound, throw the tissue to somebody on the side. Hopefully they've called pathology, but the pathologist doesn't know much either. And then they just throw the tissue in the bottles and pack it up and send it. What should be done is somebody should be looking at the core with a dissecting scope, or I'll show you in a minute another way to do it. The dissecting scope will reveal superficial glomeruli in the cortex and this bloody lines in the medulla. So in a full-length biopsy, you'll see cortex over here, maybe 80 to 90% of it, and a little bit of medulla. That would be ideal. But wait a minute. It's 2020. We got smartphones. Smartphones are, everybody has one. Nobody has a dissecting scope anymore. You can use a smartphone with good backlighting and a little stand, or if you've got a steady hand, I've been drinking coffee all morning, so I'd be having a little bit of a shake. I can get a good picture and then magnify it with my fingers. And we've actually done this. Shri has led this. He's done a bunch of these, taken a lot of pictures. And you don't need a dissecting scope. Use the smartphone that's in your pocket. Well, it'd be great if this worked every time. A good examiner is accurate 80 to 90% of the time. There's a whole bunch of reasons to misread it. There's a balance, and that's always a problem because the rocks are tipping and things are changing, and you know that next pass may be the bleeding pass. So you've got to balance the need of the diagnosis versus how the patient's doing. This is a key point. If you have a good core, you put that whole thing in formalin. Don't try to cut it up. We were all taught to cut these things. Quarters, halves, tips, this and that. Forget it. You get your good first core, you're going, you know, even if you're not going for a second pass, put the whole thing into formalin. Say it again. If you have a good core, the core goes into formalin. The second core goes into Michelle's media for immuno. If you do 4 passes or 3, the third core goes into formalin. Notice I'm not mentioning glute. If anybody wants to discuss, I hope you don't. If anybody wants to discuss why we use formalin versus glute, we can get into that.
How long after the biopsy should you see that? There's a question about how long you would expect to see gross hematuria or microscopic hematuria post biopsy.
Boy, you know, there's some nephrologists on here who'll probably know the answer to that better than me. The study that I've done is the vast majority, the overwhelming number of serious complications occur within the first 18 hours. But I do not know how long a patient persists with microscopic hematuria. Do one of you guys know, because you do biopsies yourselves or know that history? I don't know the answer to that. How long it lasts?
I mean, usually after the biopsy, there's the need for urinalysis in the short-term period is low because the urinalysis probably led to the need for the biopsy to begin with. So I don't know the answer to that.
Matt, do you know? I don't know the answer. I don't think it's very long, but go ahead.
I don't know the exact answer to that, but I do know that we used to have a practice of putting a specimen of urine like every few hours for the patient. You can kind of see it start a little bit red and then sort of fade away. But I think it's pretty rare to have microscopic hematuria over 24 hours after, but I don't know there's a reference for that.
Yeah, if you think about what the tissue's doing, just go back physiologically. For any wound, there's a whole study in pathology of wound healing, and the tissue just flaps back together. And I hope everybody heard that noise. That needle comes out and it's like, and it's trying immediately to coagulate. So unless you've got a bleeding diathesis or you've ripped open something, which is why Matt's point is good to keep looking at a UA, just look at it. Forget the microscopic, just have them pee in a cup so you can see it. That's a good idea, but I apologize, I don't know the answer. All right, this slide is, I put a double in here because you've got to remember, we can do a lot with a formalin fixed. I can do hardly anything with Michelle's except immunofluorescence. The EM comes from formalin fixed. I can do paraffin immunofluorescence, and I, meaning renal pathology, can do paraffin immunofluorescence from formalin fixation. So the good stuff goes in formalin. Then please fill out the paperwork. Give us a history. I got a history yesterday, 80-year-old female. You were waiting for more. There wasn't anymore. We'd just go around gathering 80-year-olds and, hey, line up, let's have a kidney biopsy. I mean, come on, I need some history. Now, usually that's not your fault. That's an IR's history. By the way, there's the open kit, and that design with that kind of foam was the key to this. And that's why you save everything. If you run it, everything gets flat, but that foam pops back up and it's all good. Put the paperwork in there, fill out that FedEx sheet, ship it off on your FedEx plane. Now, I know there's people from all over the world here, but there are other delivery services that can get it next day to where it needs to go. There's a picture of that big FedEx truck pulling up behind Arcana. And here's our FedEx guy dropping off half a load for us on a typical day. So all of these have to be checked in, and then all of them separately, carefully opened and separated. All right, now who's going to read the biopsy? So I asked Chastity not to put that old picture of me when my hair was still brown. It's gray now. It's not brown anymore. And Christy, one of our other renal pathologists, reading kidney biopsies. We're fellowship trained. So what does that actually mean? Well, I took a path residency of 4 years and then medical renal path for a year. This is not GU path, which focuses on tumors, bladder, prostate. When I tell people I'm a kidney pathologist, they always immediately tell me about their uncle who has renal cancer. I don't try to explain it to them, but there's a big difference. Why just fellowship training and not board certified? Because we only train 4 to 6 people a year. There are no boards. The renal pathologist has to have a good laboratory. One of the nice things about living in Arkansas is it's beautiful here. So our lab is filled with windows so that the techs aren't just in the basement like they were my whole academic career. We were always down in the basement. In the basement of Charity Hospital in New Orleans when Charity was still around. Holy moly, that was a horrible place. So we need a real renal pathology laboratory. You've got to have all the special stains. Immuno's required. EM is required. Again, it's required. I always get in trouble when I'm traveling around the world because, especially in Europe, they argue with you about that. But I've got the data. I don't talk off my nose on this. I have the data to document it. This has been true since the introduction of EM in the 60s, all the way to a recent paper in 2019 showing what you miss if you don't do EM. And that one was from Iran. Light microscopy is not easy in renal path. It's a lot easier with regular path because the sections aren't cut so thin and they're not cut in a ribbon. They're not serial. This is a serial section. We got every single bit of that kidney and laid it out on the water bath there so we can pick it up on slides. And then you alternately stain H&E, PAS, trichrome, and Jones. How do you know these are serial? Look at this glom in this one, serial. This glom in this one, serial. Next section. So we can look at things with different colors and views, and it's very important. Immuno is dark field. I'm not going to go through this. This is how you make the antibodies. Fluorescein is attached. That actually is a picture of good pastures or anti-glomerular base membrane antibody disease. Timeout. Anti-GBM antibody disease. To have that occur to you in the United States, it is more frequent to die from being hit by lightning than to get good pasture. That's how rare good pasture is. But what's going to be on your boards? I can tell you, it'll be a linear picture like that. That was an aside. So just read this slide. This is what a typical panel looks like. This is what we're looking at. There's 10 sections there. We have 13 sections for light, 10 for IF. And in transplant, you add C4D. And there may be other things that you will add along the way, SV40, other things. We do same day EM. The biopsies get here at 6 hours. For our EM, you have to have a EM microwave processor. Look at this report, though, at the bottom of the page. I actually did this during my fellowship in 1977 at the University of Minnesota. We one time did same day EM. The biopsy was done at 8 in the morning. I was looking at photographs with the staff at 11 at night. It took us 17 hours to do it by hand. But we could do same day processing even back then, all by hand. Today you can do it 6 hours because you can do microwave processing. But cutting this isn't trivial. You need a diamond knife. That's the knife. Look how little the block is. And you need this ultramicrotome. You take the tissue and you put it on this grid. You have to have a microscope in the ultramicrotome to see it. There's the tissue itself in a plastic block. There's a US penny. And there's the grid it's going to go on. Then you stick it in the electron microscope here. That's the entry point for the EM. Well, just how big is an angstrom? An angstrom. It's 2 helium molecules next to each other. And we're cutting this thing at 50 angstroms. That's 1,000 helium atoms in a row. That takes skill. We're getting to the end here. The pathologist's job is to really be able to correlate everything they see and combine it with clinical information. I am not just a technician reporting stuff out to you and letting you do it. I know a lot. I've been studying clinical medicine as well as pathology. I'm not a nephrologist, but my focus is on the medical discipline of nephrology. And it is the combination of my skill set and yours that leads to a detailed, accurate clinical pathologic diagnosis and a final report. And what always cracks me up, and this is the 100th year of Dr. Heptonstall, he's still alive, of Heptonstall's pathology, renal pathology textbook. He would love to know, and he's still quite lucid, that we're still using 18 and 1900s technology in spite of everything he's seen since being born in 1920. We still need Lister's microscope, which was the first good compound microscope to do good renal pathology. Here's the summary. Not easy to do, professionally demanding, and it's more and more important because of the therapeutic options. Use the correct technique, the correct needle, formalin first. And please, let's have a good discussion. Let's take the time to figure out what we've taken the time to do the biopsy. Let's have a good discussion. Thank you, everyone. And I'm ready for any questions or comments from the audience or whatever you guys think. Thank you.
And how you prepare the samples for electron microscopy. Can you comment a little bit more about that?
Sure. Glutaraldehyde is the classic fixative, and it is it does an excellent bonding of proteins and binding of proteins and solidifying them. The problem is glutaraldehyde needs to be made up fresh and kept cold. Nobody does that. So if you get glutaraldehyde in your kit, who knows when it was made? It's not been kept cold. It is now much less effective. Formalin, on the other hand, lasts forever, pretty much. You put it in a bottle, it'll last forever. The other thing about glute, because of its binding characteristics and the nature of the molecule, it penetrates slowly. Formalin has penetrated and done all of its work within minutes of putting the tissue into the formalin. So you get 90% of the fixation, but you get it in 3 minutes as opposed to an hour. That's why we choose formalin. Then you don't have to cut it because I'm going to cut it. If the bottle gets to me, I've got a big core. I'm going to look at it again under a microscope and find where I can see glomeruli and take a little piece off for EM. That's how we do it.
How you're able to distinguish between the different stains. It's an important thing for nephrology fellows.
Yes, so H&E is the classic stain, hematoxylin eosin, blue and red. It's the thing you did in your second year or whenever you did pathology training. That is 90%, 95% of all typical pathology stains. It provides excellent information about inflammation. It gives you some hint about fibrosis. It will also tell you about necrotizing areas, granulomas, but it isn't much help in glomerular disease.
Do you mind,
so there's
do you mind
a lot
pulling
of
up?
pink in those.
Sorry, do you mind pulling up your slide so we can see
Oh,
the,
I'm sorry.
the
Sure.
image?
Let's go back to that. I apologize. Light microscope.
And kind of along those lines, there was a request to kind of review the basic histology. So, for example, the glomeruli, tubules.
Sure. Yeah, I didn't. I kind of went by that. Let's share the. Let's go to Bingo. And I don't know whether my screen is still being shared. Yeah, my screen is still being shared. So here is a typical glomerulus with a PAS stain. So this is the entry point. We're kind of looking down from the top. This is the vascular pole. Here's the
stain.
The very pink nature of the glomerular basement membrane. It's dark, deep pink. The other thing is, look up here. Oops, let me get my laser pointer going again. Look up in here, there, and there. That is the PAS positive brush border. That's the big tip-off at low power that you're looking at a PAS stain. PAS is counterstained with eosin so that you can, hematoxylin, so the nuclei are blue, but it's that deep pink that gives it away. The glomerular basement membranes on H&E are much thicker because they're picking up every bit of protein that's in here, all the podocytes, whereas the PAS is specific for basement membranes. Notice that the PAS is highlighting the basement membrane of the tubule here. Look at that. And also glomerular basement membrane, Bowman's capsule's basement membrane. So there's Bowman's capsule, very pink, and a very, very little Bowman's capsule lining epithelial cell versus a podocyte. So that's the two hints. Basement membranes are preferentially stained, and the brush border. Let me escape out of here and go to the area where I showed the different stains. Let's share here. Let's go to the show. And so I don't have an H&E up here because we focus on the, as soon as I make sure there's no interstitial nephritis or other things, I'm pretty much quickly moving on to PAS. This is the lower power view of a PAS stain. It's a lot darker than an H&E because of that deep pink. You can even, oops, back to the laser pointer. Once I get through there, it goes away. You can barely make out at this low power. I took these pictures to show you the serial sections, but you can make out that there's basement membrane highlighting here. PS positive brush border is here in the proximals, but not in distals. Trichrome is red and blue. This one has so little blue in it, right there's some blue, because a normal kidney doesn't have blue, but this is the best way to evaluate the blue of fibrosis, which is what the blue is staining. The red is staining the cytoplasm. The other thing that the trichrome is good at is highlighting tubular injury. The red cytoplasm shows up very nicely when it's injured. The Jones silver is another basement membrane highlighter. Look at how easily that, you get a black outline here of TBMs, Bowman's capsule, and even GBMs, even at low power. So unfortunately, I cut out the whole detailed area where I do demonstrations of normal histology because I was going to talk about the how mostly. So this is the best I can do with that.
Questions and comments in the chat. Shri, did you, and Tiffany, did you want to add anything based on what you're seeing in the chat?
Going on. So basically what happens as a nephrologist, many times training, we do biopsies, but we might end up believing that once I go out in practice, I am not going to do the biopsy. IR is going to do it. But as a nephrologist, it is very important to understand the kidney biopsy result which you get has resulted from the biopsy which was performed. So as a nephrologist, you should know what an adequate biopsy is and how a biopsy is done, how it is triaged, because then you can talk to IR and discuss with them how to perform an adequate biopsy. And there are some questions in assessing the biopsy at bedside and counting the number of glans. It is very difficult because when you look at that biopsy, even under a dissecting scope, you are looking at a superficial surface, and it is a three-dimensional core which you are getting. So it is not possible even to count the number of glans when you're doing it properly. So grossly at the bedside, if you can make sure that you are in the cortex, that will help improve the accuracy of the biopsy a lot. Because And some biopsies are difficult when you have a lot of fibrosis. But if you can identify fat and medulla, the rate of inadequate biopsy can be reduced drastically. And that is very important. I'll repeat that. If you can identify fat and medulla, everything else, if you are at the right side, will be cortex. And cortex is tan. So once you have biopsied, if you remove the blood from the top of the coat of the biopsy, you can appreciate that color. So that itself will end up improving the adequacy a lot. There are a lot of questions on triaging, and Pat did go over that slide, that what is the best way of triaging. If you go over the presentation, you will be able to see that slide and you can get that answered. And Tiffany, if you are seeing anything in the chat box, if you would like to add anything, please go ahead.
And while we're waiting on Tiffany, I would like to make a comment about interventional radiology. This is something that, with this abstract that I'm putting together for ASN and hopefully a subsequent publication, I'm also working with some IR people because we need to get them trained. They are not trained. They tell you they are, but they are not. And they are in the business of doing biopsies. They have room to room to room. And they go door to door to door, thyroid, breast, lymph node. Oh, here's a kidney mass. Yeah. No, medical renal. Also what? Bang, 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 bang. Look, they're all trying to do their best. I'm not putting anybody down, but they get up to that capsule and they go, I got to get through there. Bang. And they go through the capsule all the time. So the statistics I have, when nephrologists miss, they miss shallow. They bounce off the capsule and capture muscle and fat. 95% of the time when a nephrologist misses, they miss shallow. 90% of the time when an interventional radiologist misses, it's deep. That's where the operator error comes in and the bleeding complications come in. 90% of our biopsies done by IR miss deep. They need to be trained.
Important the number of biopsies a particular place or institute will do, because if you do more number of medical kidney biopsies, the accuracy will improve. If you are doing only few biopsies a year, like less than 30 biopsies a year, it will be difficult to maintain that competency. So that is again very important. Yeah.
And from the study that I'm doing, I've got the statistics to back that up.
There's several questions in the chat about processing of electron microscopy. Can you tell us a little bit about that process and things to consider?
Sure. Processing of any tissue to get it ready to go into a block hard enough to cut is similar. The first thing you have to do with any tissue for light or EM is get the water out of it. So there's a standard protocol that you step the tissue through to get the water out, and then you go back the other way and replace it with something hard so that you can cut it. Now, microwave processing allows this to occur faster. So we use the microwave design for light microscopy, and we can really process that light quickly. And we use the microwave for EM, and we end up in a plastic block. So you're replacing the water with plastic, and that stabilizes the tissue and allows it to be cut. You'd use paraffin for light because you're doing 3 micron. You use a hard plastic for EM because you're doing angstroms. So the processing is done automatically nowadays, but when I came along, you could do it by hand. You just sat there and set a timer, then move the tissue along from more and more through alcohol, and then you got to get the alcohols out, and then finally you can work it into paraffin or into the plastic. So it's a alcohol, another product to remove the alcohol, and then moving it after the alcohol's gone into the media that's going to hold it, the block.
Thank you. You mentioned, aiming for that lower pole. Is there any additional consideration when doing a kidney transplant biopsy with respect to the kind of safest place to aim for?
The biggest thing in doing a transplant, remember, you're talking to a pathologist here, and I've just done all this from reading and listening. But it's a lot of reading and a lot of listening over time. So we had a IR-guided transplant biopsy. Transplant biopsy should be trivial the other day because the way the kidney was placed in there was too much bowel all over the place. So there's all kinds of there's a whole separate set of issues when you do a transplant. You still should be aiming for the lower pole, but it's in a different location. It's going to take a different angle. And there are other things like bowel that can get in the way depending on where it's been placed. But the idea is the same. You want that angled shot, not aiming for vessels.
Thanks for that. I think we're getting ready to wrap up here. Shri, did you have anything else that you wanted to add here?
There were a lot of questions on the tube processing and all that. So Pat has written articles on that. So I have shared them as handouts if you download that. And there are many questions on transplant, how to do that biopsies. So we have shared some handouts which can answer all the questions which were raised in the chat box. But if you have any other further questions, yeah, you know our email. So yeah, people can email us, yeah. And the last question, meeting recording will be available, yeah. So you will be able to have that. So that was all from my side, Samira. So unless,
Okay.
yeah.
From Matt and I, thanks to everyone for joining the session. Special thanks to Dr. Walker for this great presentation. We're hoping to continue this pathology series and looking forward to everyone's feedback on how we can improve this in the future. Our next session will be focused a bit more on the pathology. And so we're hoping to, for our next session, in conjunction with the nephropathologist, have a session on introductory pathology, kind of going through what that normal biopsy looks like, so that you can have a better understanding of what abnormal is. And so again, thanks everyone for coming. And please reach out to us with any additional questions or concerns. Enjoy your weekend and stay safe, everyone.
Thanks a lot.
Thank you.
Bye-bye.